Okay, assalamu alaikum and good morning to everyone. I hope everyone's having a really great day, a really great Ramadan, both spiritually and academically. I'm Bushra Rasheed. I am a fourth year medical student, and today I'll be talking to you guys about hemoglobin electrophoresis, and we'll talk about hemoglobinopathies. I do realize that this is a recorded lecture. However, you guys are free to ask me any questions that you want, spam me with comments, or just like literally say anything you want. Any kind of constructive criticism, I would appreciate that as well. Here's my email at the bottom of the screen, as well as my phone number, so you can WhatsApp me if you'd like. Okay, so we'll be talking about the pathophysiology of hemoglobinopathies. First of all, we'll discuss the principles of hemoglobin electrophoresis and HPLC. That basically stands for high performance liquid chromatography, and how these different sort of laboratory tests are used to diagnose said hemoglobinopathies. We will then be interpreting and recognizing the different types of laboratory results for these hemoglobinopathies, basically interpreting the results from these tests. Okay, so first we're talking about hemoglobin. Okay, we all know this is basic high school biology, but red blood cells, right? Red blood cells have hemoglobin. The structure of hemoglobin is made up of heme and globin from its name. Now, globin is the protein aspect. Globin is composed of four chains of proteins. Heme, on the other hand, is a little bit more complicated. It's this organic ring-like structure, which is protoporphyrin, which has iron bound to it, so that's the heme portion. Now, one hemoglobin is composed of four globin chains, and each of these globin chains is actually bound to one heme. So that the entire hemoglobin compound has four globin chains and four hemes attached to each of these globin chains. So the alpha globin chain, the main type of hemoglobin that we have in our body, hemoglobin A, is composed of two alpha and two beta globin chains. The alpha globin chains, as it says here, is 141 amino acids, and the beta globin chain is 146 amino acids. Okay, so now we'll talk about the genetics of these globin genes. Now, why this slide is as important as it is because this is the basis of all the disorders that we're going to talk about. If you understand this, you will understand why all of these problems are occurring, and that will help you to diagnose them, for example. So we have chromosome 11 and chromosome 16. These are the most important ones that we'll talk about in this lecture. As you see in the image for chromosome 16, there's a total of four different alpha genes, right? There's a total of four different genes that are responsible for producing all the alpha globin chains in your body. Similarly, the number is only 2 for beta. There's only 2 beta globin genes, or alleles, you could call them, that are responsible for the globin genes, the globin chains in your body. Now, each of these chromosomes, this is just high school biology, but each of these chromosomes you get from, one of them is from your mom, the other one's from your dad, right? From when the egg fuses with the sperm. So alpha 1 and alpha 2 on this chromosome could be, like, for example, from your mom, and the second set would be from your dad. And so this is important in the implications that it has, that you can, again, if your parents have the mutated versions, that's what you're going to get too. Similarly, one beta on allele on one of them, and then another on the second one. One last thing I want you to know from this slide is that we talked about how hemoglobin is a tetramer. It has 2 alpha globin genes and it has 2 beta globin genes. So 2:2, which means that the ratio between alpha and beta is 1:1. For example, if you were to have a mutation in the beta gene, right here, that would result in decreased beta production, and you would have so much more alpha, not enough beta to go and merge with that, and so that would lead to lots and lots of different symptoms down the road. We will talk about that in a bit. Okay, so yeah, pretty much this is what I explained earlier. So chromosome 16 is responsible for alpha, and 11 is responsible for beta. We said there's 4 different alpha genes or alleles. Each of these is responsible for 25% of the total alpha production in your body. Similarly, There's only two beta ones, so each of these genes is responsible for 50%, roughly, for all the, sorry, for all of 50% of the total beta production in your body. Okay, so these are the different kinds of hemoglobins that we have in normal adults. It's important to note that this is the hemoglobin that's available in adults. I'll explain to you why. So we have hemoglobin A, which is composed of 2 alpha, 2 beta. This is the one that we were talking about just earlier. This is 98%. This is 98% of the total hemoglobin in your body. Next, we have hemoglobin F. The F stands for fetus or fetal life. So this is the hemoglobin that's present in fetuses in the womb. And why that's important is because this hemoglobin has an increased affinity to oxygen. Now, what that will do is, because when the mom's blood arrives in the placenta, she's gonna have the normal adult hemoglobin A, right? But the baby's blood that's arriving to the placenta is gonna have hemoglobin F, which has a higher affinity, and so it will take the oxygen from the mom's hemoglobin to the hemoglobin F, and that will then circulate in the baby's body to provide the baby with enough oxygen. Hemoglobin F is composed of 2 alpha and 2 gamma chains, whereas the last type, which is hemoglobin A2, is composed of 2 alpha and 2 delta chains. Now, hemoglobin A2, the normal amount of this hemoglobin is less than 3.5%. Now, why I've highlighted this here is because it's an important diagnostic factor in diagnosing the different hemoglobinopathies when this amount increases more than 3.5%. So, yeah, you need to make sure that you memorize this number. So, when we talk about hemoglobinopathies, there's 3 main categories of these inherited abnormalities. We have structural, or qualitative, and then we have quantitative, and then there's the HPFH condition. So qualitative means that the quality of the chains has been altered. The structure has been altered. How that happens is there's some sort of a mutation that occurs in the amino acid sequence in the DNA, which leads to, again, incorrect DNA, and that will translate to incorrect proteins. And so the globin chains will be totally incorrect, right? They're not gonna function optimally because they don't look like what they're supposed to. And one such example of a disease would be sickle cell. The second category is quantitative. So the production of the globin chains is either reduced or absent. Yeah, so there's no problem with the structure of the globin chains. It's just the amount that's reduced, and one such example of a disease would be thalassemia. Lastly, we have hereditary persistence of fetal hemoglobin. Now, this is a very rare disorder, and it's benign. It's usually asymptomatic, and an individual will live normally for their lives. It's basically when the gamma globin, remember how we talked about the gamma globin in HbF? So that gamma globin does not make the switch to beta globin. So the hemoglobin F does not turn into hemoglobin A. And usually it's, again, like I mentioned earlier, it's usually asymptomatic. It's usually not going to present as a life-threatening, entity or anything. But if this condition were to occur in a woman, and say that woman was to get pregnant, now that would be a problem because the mother has hemoglobin F and the baby has hemoglobin F. So the oxygen transfer in the placenta would be impaired. And so the baby would not be able to survive. Okay, so yeah, most common hemoglobin abnormalities, we have sickle cell, we have HBC disease, and HBE disease. HBC and HBE disease, they're not that important for you to know. But they are very similar to sickle cell. I'll talk about them, inshallah, later in detail. And then we have thalassemias, alpha and beta. Okay, so the most prevalent kind of hemoglobinopathy is sickle cell anemia. The most prevalent kind of hemoglobinopathy is sickle cell anemia. Now, if we were to look at what causes sickle cell anemia on a molecular basis, we would realize that this is a problem in beta globin chains. And what chromosome did we say was responsible for beta globin? That's right, chromosome 11. So there's some sort of a mutation that occurs in the chromosome 11 which causes one of the glutamic acid amino acids to be replaced by valine. Valine right here. Oh, hold on. Yeah, valine right here. So the glutamic acid is replaced by valine, a totally different amino acids. Now, if you've taken chemistry in high school, you know that sorry, you know that certain amino acids are important because they're responsible for making certain types of bonds with other amino acids, right? We have hydrogen bonds, we have ionic bonds, we have covalent bonds, just to name a few. And so if you're replacing the amino acid with a completely different amino acid, the bonds that are going to be formed within this protein are going to be different. And when the bonds are different, the shape of the protein will be different. And so we know how important the proteins and their shapes are, you know, the lock and key mechanism and all of that, enzymes and all of that. We know that proteins are supposed to have specific shapes to be able to perform the functions that they do. And so now that the globin chain, the beta globin chain specifically, no longer looks the way that it has to, that's going to be a problem. It's not going to be able to function as well as it's supposed to. Okay, types of sickle cell hemoglobinopathies. So, since sickle cell is an autosomal recessive disorder, I'm sure we all know what that is, high school bio, right? We can either have sickle cell traits, which is the carrier state of the condition, or we can have full-fledged sickle cell disease, sickle cell anemia, and that is going to be obviously way more severe than the carrier state. It's important to note that the sickle cell trait, aka the carrier state, is not going to have any of the symptoms of sickle cell disorder because we have an adequate amount of normal hemoglobin present. So yeah. Now this picture is, I don't know if about you guys, but I feel like it's confusing. So I made something of my own. I feel like these tables are so much easier to talk about when we talk about like recessive or dominant conditions. Just because we've taken them in high school, I think it's easier to understand. Okay, say you were to have a couple, a mother and a father, who they both of them were carriers. Both of them don't know that they're carrying this condition. So the mother has HbA and she also has HbS. The father, once again, HbA, HbS. Now, HbA basically refers to the beta globin gene that is normal, and HbS refers to the fact that the beta globin, one of the chromosomes of the beta globin genes, is faulty or mutated. The glutamic acid has been replaced by valine. Now, if these two individuals were to get together and have a child, what were the odds of them producing a completely normal child, completely healthy child, or a child who is a carrier, or a child who actually has sickle cell disease? Now, we can look at it as, we can basically look at it in this table. If an egg that will carry an HbA was to fuse or get fertilized by a sperm that was HbA, your child would be completely normal. On the other hand, this and this, basically these two conditions, the child would be a carrier or have sickle cell trait. And then we have this child right here, who, because he inherited the HbS from his mom and the HbS from his dad, he now actually has sickle cell disease. And again, like, I don't need to explain this to you guys. I'm sure you guys are smart and you know. But each of these boxes, since there's 4 boxes in total, each of these boxes is 25% of probability. And so the probability of this couple having a completely normal child is 25%. The probability of them having a child with sickle cell trait, because it's 2 boxes, both of these boxes right here, is 50%. And the probability of them having a child with the disease is another 25%. Okay, so next we talk about the pathogenesis, how, like, what exactly happens in sickle cell. Basically, when you have some sort of an oxidative crisis in your body, some sort of crisis that leads to a decreased oxygen tension, examples of such events would be like infections, or if the woman's pregnant, or some sort of acute stress, any of these events, this would lead to an abrupt decrease in the amount of oxygen in the body, because all the oxygen is going towards these events, right? And so when the hemoglobin gets deoxygenated, it turns into the sickle cell shape. And I don't know if you guys like know what a sickle is, but it's basically this knife sort of thing right here in the corner. I don't know what it's used for. I don't know if it was used to fight war. I don't think so. I don't think it was used to fight wars, but I think like farmers use it to cut crops or something. I don't know. But yeah. So what's important here is the shape of it, right? So if I was to zoom you guys in, all these cells that I've sort of circled here, so we have this one right here, we have this one, another one is this. So they're all like sort of a sickled shape, right? And the thing about the sickle shape is that it actually helps these hemoglobin molecules to be packed tightly on top of each other. And it will aggregate together, they will polymerize together, and they will go and get stuck in capillaries, right? So when that happens, something called a vaso-occlusive event can occur. Vaso-occlusive from the name, vessel, occlusive, that the vessel has been occluded. This kind of an event can occur, and what's basically going to happen is the capillaries get blocked, the blood supply to an organ or a tissue is blocked, and so because of the lack of oxygen to that organ, ischemia or infarction can occur. The cells of that organ are most likely to die. And yeah. Sorry. There's another important thing that I wanted to tell you guys about in this picture. You see a lot of these target cells right here. These cells, all of these cells. We're going to talk about this later, but this is one of the ways that you actually diagnose sickle cell is through a peripheral blood smear. That's what this picture is. So yeah, this is what I talked about earlier, that they're going to stick together in small vessels, and then they're going to go and block the vessels, leading to ischemia, infarction of small vessels of the hands, the feet, the lungs, and the spleen. Now, the spleen is really important, and I'll talk to you guys about why. But I first want to make sure you guys know what ischemia is. I'm not sure. You probably already know, honestly. But ischemia is basically when not enough oxygen gets transported to the tissues and the tissues die off. Okay, so now we talk about why the spleen is so important. So remember how we talked about these vaso-occlusive events that occur in sickle cell? So those are going to happen in the spleen more often than any other organ of the body. And so when like these aggregates go and they occlude the vessels or the capillaries of the spleen, what's going to happen is that there's going to be blocked blood supply for a small part of the spleen, and what's going to happen is ischemia, necrosis, infarction. And so this very small, tiny part of the spleen is going to die. Now, spleen, like many other tissues and organs in the body, cannot regenerate itself. So the part of the spleen that died is dead. You're never going to get that part of the spleen back, right? What's going to happen instead is fibrosis. So we're going to have fibroblasts that arrive to the place of injury. They're going to lay down ground substance. They're going to lay down like these gags and all those other things. You're going to have collagen deposition, and this leads to a fibrotic mass. Now, when this happens repeatedly over a long period of time, like this will keep on happening again, you're going to have another vaso-occlusive event. You're going to have another area of ischemia. You're going to have another fibrotic part of the spleen. This keeps happening over and over until the entire spleen will now be a fibrotic mass. This process is actually known as autosplenectomy. Ectomy means removal of the organ, but in this case, you don't actually remove the spleen. It just, I guess you can say it just becomes diseased and fibrotic, and it's no longer going to work, so it's almost as if you removed it, since it's not going to be doing its job. In terms of what investigations you want to order for sickle cell, first line is all of a CBC. Now, this is not just for sickle cell, it's for basically any other conditions that you might have, that you might present to the clinic with. The doctor is always going to ask you, or ask the nurse or the staff for a CBC, because it's like the least invasive sort of investigation that can be done, right? They take your arm, they draw out a sample of blood, they send it to the lab. It's the least invasive, and it can tell you so much about what's going on in the body. So a CBC basically has, or will tell you about the patient's red blood cell count, the hemoglobin, the hematocrit, MCH, MCV, white blood cells, platelet count, etc. And that can give you important clues about what's going on with the patient. For example, if his hemoglobin is extremely low, you realize that maybe, like in our case, the patient is having hemolysis because he has sickle cell. So yeah, that's pretty important to know. One other thing that before we move on is a CBC with differentials. That's basically, just for your information, it's basically when you have a regular CBC, but the differentials part is when you have the amount of red blood cells that are increased. So what type of red blood cells? Eosinophils, basophils, which one of these exactly is increased? Because a CBC, a regular CBC, is only going to tell you that the white blood cells in general are increased. So yeah. So, okay, moving on to the peripheral smear, that's pretty important too. So when you draw out blood for the CBC, you can just send some of it to the lab for a peripheral smear. And there's so many different things that you're going to be looking for if you suspect your patient has sickle cell. Some of them are, you're going to actually see the sickled cells themselves. You can see some target cells, which are ones I just showed you earlier. You can see marked anisocytosis and poikilocytosis. Now, what are these terms? Anisocytosis and iso, not the same size, right? So cytosis, an increase in the number of cells that are not, and iso, not the same size. And poikilocytosis, an increase in the number of cells that are not the same shape. Next, we're going to have an increase in the amount of fragmented cells. That's basically because these red blood cells, the RBCs that have this faulty hemoglobin, they're going to be getting destroyed, right? They're gonna die off prematurely and leave these fragmented cells behind. Next we have nucleated red blood cells. Now the main reason for these nucleated RBCs is that we already know that there's hemolysis taking place, right? All of these sickled celled red blood cells, they're not healthy. They're not gonna survive the 120 days. They're not gonna go through the lifespan of a regular red blood cell. So what happens is that the red blood cells the bone marrow is going to realize that there's a decrease in the amount of RBCs in the body, and it's going to want to try to push out more red blood cells. Now, in doing so, it's also going to be pushing out the premature RBCs, which are the nucleated red blood cells. I'm sure you know about the life cycle or the lifespan of the RBCs. And yeah, so lastly, we're also going to be seeing Haemoglobin bodies. Now, what those are is basically inclusions. I will show you guys a picture of what that looks like in just a second. But Haemoglobin bodies are inclusions in red blood cells. And these inclusions are usually taken out by the spleen, because the spleen is going to filter the blood, make sure that all the RBCs are looking good, looking healthy. But these red blood cells with inclusions, they're going to bite out the inclusions. And when you do see Haemoglobin bodies, it's basically when you have splenic dysfunction. The spleen is not able to take them out. And we know why sickle cell has splenic dysfunction, because of the autosplenectomy we talked about earlier. So let me zoom you guys into the picture here. Okay, so we see a lot of weird looking cells. We are seeing sickle sort of cells here, right here. We can see a few target cells. This one right here is a target cell. Where else? This one at the top could be a target cell. Oh, and we see a Haemoglobin body right here. And yeah, you see like different shapes of cells, like this one for example. There's weird sizes and isocytosis. And yeah, pretty much this is what a peripheral smear is going to look like for a patient who has sickle cell. If you do see sickle cells, you will then move on to the next part of the investigation, which is a sickle solubility test and a hemoglobin electrophoresis. Okay, but before moving on to that, we also need to keep in mind other findings that we might see. So the white blood cell count may be elevated because of the nucleated red blood cells. The bilirubin might be elevated, and the reason for that is actually because when you have these sickled RBCs, they're obviously going to get destroyed. So you're going to have all this hemoglobin in the blood, which is going to get broken down, right? So heme and globin. Globin is just proteins. Proteins gets broken down to amino acids. It gets used up for other proteins. We're good. But for the heme part, heme is made up of the protoporphyrin ring, right? This protoporphyrin gets converted to bilirubin. And because there's so much of this hemolysis occurring because of the sickled cells, where there's not going to be enough room in the body to be recycling this bilirubin, and so there's going to be an elevation in the blood, which is why the bilirubin levels are elevated in this case. And lastly, you might actually see urinary casts or traces of RBCs in the urine. Okay, so moving on to the solubility test. This is basically done to identify HBS. Why can we identify hemoglobin S is because it's a lot heavier than the other hemoglobins, and it's insoluble compared to the other ones. So you add a reducing agent, and what that's going to do right here is that it will precipitate. So HBS precipitates so much easier than other hemoglobins, and so as you see in this picture right here, it's completely opaque. You cannot see the lines pass through, and that basically means that HBS is present in this test tube. HPLC, high performance liquid chromatography, is basically chromatography. I'm sure you guys know that from high school. So what you're gonna see in the results is basically how much of each of the different kinds of hemoglobins there are. So as you see in the first picture, you have around I would say around 30% of hemoglobin A and around 30-ish% of hemoglobin S. Those are the two most predominant types. So this person is most likely, since he has half S, half A, most likely a sickle cell trait person. On the other hand, right here, it says S heterozygote, so yeah, we're right. So in the second graph, we have hemoglobin F and hemoglobin S. So what's going to happen in this scenario, why do we have so much F, is because when you have a faulty kind of hemoglobin like S, it's not the normal kind, it's not HbA, so the other kind of hemoglobins would be more predominant in this kind of a person as well, and F is one of them. And so this person is most likely one who has sickle cell anemia, the actual disease, not the trait. This is just a diagram for me to explain to you what exactly electrophoresis is. It's basically where you have like this gel-like substance in this glass tank sort of a structure, and you have these wells right here, and you put your sample inside, and what you're going to do is run electricity or run an electric current through the gel. As you can see, the top is a negative electrode and the bottom is a positive electrode, and so the negative things will actually run down faster because they're attracted to the positive electrode, and the smaller segments are going to travel faster than the larger segments, just because they're lighter, and so they can travel faster more easily. And so this is how you can separate the different hemoglobins present in a person's sample, in a patient's sample. Okay, moving on to thalassemia. So we said earlier that thalassemia is a quantitative defect. It's basically a decrease or complete absence of the production of either alpha or beta chains. Alpha thalassemia is when the alpha chains are reduced, and beta thalassemia is when the beta globin chains are reduced. And yeah, moving on. I want you to take note of the hemoglobin structure in the top left corner. This is something I explained in the beginning too, but this is basically, this entire thing is one hemoglobin molecule. So as you see, we have 2 beta, 2 alpha globin chains, and each of them in the center part right here has a heme attached to it. Each of the globin chains has a heme. So one hemoglobin molecule is 4 hemes and 4 globins. So the sequence of events that occurs in thalassemia would be, you would first have a mutation on chromosome either 11 or 16. Defect in the globin chains would occur because of faulty genes. Yep, because of some sort of a mutation, inherited defect. Globin chain synthesis would be unbalanced. So you're either going to have 2 less of alpha, which means that you have an excess of beta, or you have 2 less of beta, which means that you have an excess of alpha. That's going to form hemotetramers. Now, what that is is basically when you have, again, we talked about how alpha and beta exist in a 1:1 ratio, right? So you have decreased alpha globin chain production. For example, you're going to have excess beta globin chains that have no alpha to bind with. And so you have all of this unpaired beta globin chains that are just going to bind together with each other and form these hemotetramers. And this is abnormal, right? So they're going to be insoluble. And they form like these inclusion thingies in RBCs. They're going to precipitate in these RBCs. What's going to happen next is that the spleen is going to recognize that these RBCs are not normal, and so they're going to be destroyed. RBC hemolysis takes place. When you have so much hemolysis on such a large scale, it will lead to ineffective erythropoiesis in the bone marrow. Again, the bone marrow is not going to be able to effectively produce the right amount or the right kind of RBCs that our body is actually in need of. And yeah, so you're going to have, because of the RBC hemolysis, you're going to have a compensatory overproduction of the other chains. So too few alpha, okay, now you're going to produce excess alpha, excess beta, sorry, excess gamma, excess delta chains that we talked about earlier. So this slide right here basically summarizes everything that you need to know about for, alpha thalassemia. Remember how we talked about how alpha thalassemia has 4 alpha globin chain genes? Yeah, so we're going to talk about it in that aspect. So one locus, in the beginning of this picture right here, this right here, one locus means that only one of those 4 alpha globin genes are mutated or defective. This will lead to the condition known as alpha thal trait or alpha thalassemia trait. It's going to lead to this genotype right here. So you're going to have 2 completely normal alphas, and then one of the alphas on the second chromosome is going to be altered or mutated, and that will lead to an asymptomatic phenotype. Now, asymptomatic is because, again, we said that each of these is responsible for 25%. Each of these alpha entities is responsible for 25% of the total body's alpha globin chain production, right? So with one of them missing, you have 75% of the chains that are still being produced. And that pretty much is enough for your body to be able to cope with. And so you're going to be asymptomatic right here. Okay. 2 loci. So 2 loci mean that you can have 2 alpha genes mutated, right? Now, these 2 alpha genes can be on the same chromosome as in the first example, or they can be one on each of the different kinds of chromosomes. This will lead to alpha thalassemia minor, okay? Not trait, it's going to lead to alpha thalassemia minor. The patient is going to be mostly asymptomatic, but will have a decreased MCV, so will have microcytic anemia. Now, this anemia isn't that bad. It's not the kind of bad where you're going to need transfusions. You could probably just give them supplements, and it's not going to get resolved, of course, but their symptoms will improve. With 3 loci, you have something called HBH, so you have hemoglobin H. In this scenario, sorry, I've drawn the wrong picture here. Let me just correct it really quickly. So it's the opposite of what I drew. Okay, there we go. So you're gonna have 3 loci that are like mutated, and so only one of the alpha genes is going to be actually working, and this is gonna lead to a 75% reduction in the alpha globin chain production. And as you can imagine, it's going to lead to pretty severe symptoms, moderate to severe hemolytic anemia. Now, this is the kind of anemia that's going to require transfusions. The patient's going to have symptoms of weakness and, the typical classical symptoms of anemia. And yeah, so explaining, further elaborating what the hemotetramers meant, or hemoglobin H meant, is you don't have enough alpha chains, and so the beta chains are just going to start combining with each other, and this is going to give the insoluble. Remember how we talked about that earlier in this picture right here? Yeah, the insoluble hemotetramers. And so because of those insoluble hemotetramers, increased RBC hemolysis will take place, and yeah, this is known as hemoglobin H disease. Then we have a problem that can occur in 4 loci. Now, this is when there's a defect in all 4 of your alpha globin chains. You don't have any alpha globin chains left. This is known as hemoglobin Bart's disease. Once again, hemotetramers will form, but this time they're mostly with gamma tetramers, and this condition is known as hydrops fetalis. Why that is, when you have absolutely no alpha chains, you're not gonna have any hemoglobin. Like there isn't gonna be one RBC in your body that's normal. And so hydrops fetalis, as the name suggests, this fetus will die in utero, because once again, there are no effective RBCs for the circulation of the baby. And this is known as hemoglobin Bart's disease. This is pretty much what I've already explained. Yep, it's exactly the same thing. And yeah, 2 gene deletion leads to mild microcytic, yep, when the MCV decreases. 3 gene deletion is hemoglobin H disease. Something that I did not mention earlier is when hemoglobin H disease, the symptoms that you have are not just anemia. You're going to have marked microcytosis, splenomegaly, and bone marrow erythroid hyperplasia. Now, why the hyperplasia is because, again, you have anemia, you have RBCs that are being destroyed. Why do you have splenomegaly is because the destroyed red blood cells are going to lead to an overworking spleen, hence it will enlarge. And yeah, so when you have this anemia, your bone marrow is going to be working harder to spit out more RBCs to make sure that your circulation is effective, it's working, and so you're going to have bone marrow hyperplasia. And then the 4 gene deletion, like I mentioned earlier, is just hydrops fetalis. Yeah, that's pretty much it. It's just Bart's disease, and yeah, it's not compatible with life, and the fetus is most likely going to die or pass away in utero. So moving on to beta thalassemia. So remember how we talked about earlier that you have hemoglobin F, that's the predominant hemoglobin during fetal life, and then this hemoglobin F has to convert to hemoglobin A, which is the adult form, and for this switch to occur, the 2 gamma chains in hemoglobin F need to convert to beta chains in hemoglobin A. And so this switch doesn't happen until several months after birth. And so you're not gonna notice any symptoms at birth. You will notice the symptoms once the switch begins to occur. The symptoms of, anemia, just how like fatigued the baby is, maybe he's not sucking properly, all those different sort of symptoms that might present. We also talked about this earlier, but there is going to be a compensatory increase in the gamma and the delta chains. Now, why that is because you have less beta, you have more alpha. The alpha is going to need something to bind with, right? So it's going to choose to bind with delta, gamma, producing hemoglobin F and A2. This is important for diagnosing, for the diagnostic parts of the procedure. So you're going to see an increased amount of hemoglobin F and A2 in the electrophoresis results. The genetic background of beta thalassemia. So what's important here is that there's 3 different variations of the beta globin genes that can occur. One is obviously normal, completely normal. Then we have this beta 0 and the beta plus. So the beta 0 refers to a complete absence of the beta production, whereas the beta plus is when there's a partial decrease in the production of the beta chain synthesis. Now, I am aware that they're not necessarily called beta 0 and beta plus, but I can't remember what it's called when the 0 is in the superscript, so we're just gonna ignore that for now. All of this, like I've also mentioned earlier, how there's an imbalanced synthesis of the chains, decreased RBC hemoglobin, it's going to produce hypochromic microcytic anemia. Specifically, the excess alpha chains are going to precipitate, leading to hemolysis of the RBCs in the bone marrow. So as they're being produced, they're also being destroyed. This is called ineffective erythropoiesis, and there's going to be increased hemolysis of these RBCs that are faulty in nature. Thalassemia inheritance is pretty much the same as sickle cell. It's an autosomal recessive inherited disorder, so you're going to need both your parents to be carriers for your child to have severe thalassemia. Whereas if your child is a carrier as well, you're going to have thalassemia trait. Now, severe thalassemia, I've sort of mentioned here, is because of a nonsense mutation, and that's basically when you have a stop codon. Because of a gene mutation, there's an introduction of a stop codon in the middle of the entire DNA sequence, and because of that, the protein is going to be cut prematurely, and so you're not going to have the full protein, and you're not going to be able to produce enough beta globin chains. So yeah, because of the fact that we have the three different types of variations of beta alleles or beta genes, that's why we have like so many different types of beta thalassemias that can occur. We have the beta 0 and the beta plus, and then we have the completely normal beta. There's 3 different variations, right? So for a normal person would have 2 completely normal beta chains. If you were to have beta thalassemia minor or beta thalassemia trait, you would have at least 1 normal in both of these cases, and the second one could be abnormal. It could either be a complete block in the production, as in beta 0, or it could be a decreased production, as in with beta plus. We then have beta thalassemia intermedia, which is when both of them are faulty, they're just not the same. So one of them is a partial, you're still producing some. One of them is a partial block, one of them is a complete block. And then thalassemia major is when both of them are the complete same type. Beta 0, beta plus, beta plus. Sorry. And yeah, so the worse, the lower down you are on the beta thalassemia like chart, the worse obviously your symptoms are gonna be. The lower your hemoglobin is gonna be. So minor or trait is 10 to 13. Hemoglobin's in grams per deciliter. Intermediate 7 to 10, and major, which is also known as Cooley's anemia, is less than 7. That is very, very low. And yeah, hemoglobin analysis, we already talked about how hemoglobin F and hemoglobin A2 specifically will be increased in beta thalassemia. Obviously, the increase is going to be proportional to how worse the condition or the prognosis is. Now, this little screenshot is from this video that I found was super helpful by this YouTube channel called Medicosis Perfectionas, if you want to check it out. But so basically, this is only for beta thalassemia major, which, if you recall, is when you have 2 of the same gene alleles. So you can either have 2 beta pluses, or you can have 2 beta zeros. So as it shows you here, you're gonna have a complete block in the beta globin production, or a very, very greatly reduced beta globin production, because of which you're going to have an excess of alpha globin chains. Obviously, they're going to clump together and precipitate, leading to hemotetramers, which in the bone marrows, they're just going to die off. They're going to be killed, and this is known as ineffective erythropoiesis. If these hemotetramers survive long enough to be transported out of the bone marrow, the spleen most likely will catch it and will destroy them. So this is going to lead to something known as hemolytic anemia. When you have increased amounts of hemolytic anemia, the kidneys are going to sense how your hemoglobin levels are very low and secrete EPO, which is erythropoietin. This erythropoietin is going to lead to erythroid hyperplasia in certain organs of the body. So you can have medullary erythroid hyperplasia, which is basically the erythropoietin telling the bone marrow to increase its production of the RBCs, because we have more hemolysis. We need, obviously, when RBCs are getting killed, you need to produce more to keep the body functioning. And so this EPO is going to go to the bones, tell it to increase its production, amp up the production of RBCs. You're also going to have extramedullary erythropoiesis, and what that basically is that when the bone marrow does not produce enough RBCs, the bone marrow is going to recruit certain organs to help it in the manufacture of RBCs. Now, these 2 organs are the spleen, which is right here, and then the liver. It's going to lead to something known as hepatosplenomegaly, because they're both working overtime, right? So they're going to increase in size. Also, the skull, the bone in the skull is also going to be recruited to produce these RBCs, and it leads to this appearance of hair on end or crew-cut skull. I will show you what that means shortly. Lastly, because you're having so much hemolytic anemia, you're going to need, obviously, iron transfusions, right? You're going to need blood transfusions because your own blood is getting destroyed. In that case, it can lead to an excess of iron in your body, and that can lead to iron overload, and hemochromatosis. Yeah, and lastly, I've explained this before, but remember how when you're breaking down the RBCs, you're gonna have so much hemoglobin, and hemoglobin gets broken down to heme and globin. The globin is the protein, amino acids, whatever, used for other proteins. But the heme portion has protoporphyrin and has iron. The iron can be used pretty much for production of more RBCs, but the protoporphyrin gets broken down to form bilirubin, unconjugated bilirubin. And that's going to lead to hyperbilirubinemia. Yeah, exactly. And yeah, that's pretty much it. This is a very good sort of summary slide for beta thalassemia. Okay. So this is the hair on end appearance we were talking about. Do you see how, like, it just seems like the skull has like hair? It looks like stubble low-key, but it's like, this is what's known as the hair on end appearance. And there's other bone deformities too. You have frontal bossing, you have maxilla hyperplasia. These are known as thalassemic facies, and this is what a child's face could look like if he had thalassemia. Moving on to this picture, this has the typical characteristics of a child with thalassemia. This is a peripheral blood smear. Sorry. You have nucleated red blood cells in the circle right here. You have different sizes of red blood cells, which is known as anisocytosis. You have Haemoglobin bodies, again, because the splenomegaly is working overtime. It's not going to be able to work as well in removing the Haemoglobin bodies. Some more Haemoglobin bodies. You have target cells. You have nucleated, I've already talked about that actually. And then we have different shapes of red blood cells known as poikilocytosis. In terms of morphology, so again, mild thalassemia is going to relate to mild symptoms, and then we have severe thalassemia, which is going to lead to severe symptoms. Mild thalassemia leads to a mild anemia of the microcytic hypochromic variety, and severe thalassemia is obviously going to have severe anemia, marked anisocytosis, poikilocytosis, and nucleated red blood cells. So this picture we saw right here, this peripheral blood smear, was probably of a patient with severe thalassemia. Either thalassemia intermediate or more likely thalassemia major. In terms of treatment, patients with mild thalassemia, because the symptoms are so mild, you don't really need treatment. But with severe anemia, they're gonna need transfusions for sure, because their blood is getting hemolyzed. If the case is bad enough, you might even need a bone marrow transplant. Now, laboratory diagnosis of beta thalassemia. It is clinical history is very, very important to know what exactly the patient is feeling. You need to be able to place all the symptoms of anemia. If a child presents to you with, for example, the thalassemia facies, the facial symptoms of thalassemia, you can suspect that the patient has been having thalassemia. There are certain screening tests and certain confirmatory tests. So for screening, we have CBC. You're going to look at the hemoglobin, which is going to be low. The MCV, it's going to be low. MCH, HC, it's all going to be low because the patient has hypochromic microcytic anemia. Looking at the peripheral blood smear, presence of target cells, NRBC, nucleated red blood cells, presence of, I forget the name. But yeah, Haemoglobin bodies, for example, anisocytosis, poikilocytosis. We can then look at the iron profile and the HPLC. But if you wanted to confirm the diagnosis, you would be looking at hemoglobin electrophoresis, for example. You would be looking at chromatography. You can look at the globin chain ratios. Do they exist in a 1:1 ratio or no? The alpha and beta. And then lastly, molecular studies, genetic studies, etc. Electrophoresis, I've already sort of talked about electrophoresis, so we can skip the slide. Okay, the juicy part. Okay. So, let's try to do this practice activity together where we try to place what diagnosis the patient has based on his electrophoresis findings. So the first entire row that you see here is just the control. This is just to show you that what the A band is going to look like, what the F band will look like, the S band, and the C band, okay? Moving on to patient number 2, all of the hemoglobin is A. And we all know that is normal. 98% of your hemoglobin is supposed to be HbA. Moving on to patient 3, we can see that the majority, I mean, it's sort of split in half, where half of his hemoglobin is A and the other half is F. In this case, we can't really comment on this unless we know the age of the patient, because up until like 6 or 7 months, this is normal. Having like some of hemoglobin A and some hemoglobin F, it's considered normal. Looking at patient 4, we can see that he does not have any other strip. He only has hemoglobin S, which means that he has sickle cell disease. All of his hemoglobin is HbS. Moving on to 8, for example, half of his hemoglobin is A, the other half is S. So this means that he has half HbA, half HbS, and that just means that he has sickle cell trait. Same with patient number 6. Patient number 7, C is not really in your syllabus, like you're not required to know it, but I'll just explain it to you. It's hemoglobin C is pretty much very similar to hemoglobin S, in that you know how the glutamic acid is replaced by valine in hemoglobin S. For hemoglobin C, the glutamic acid is replaced by lysine, and so it's pretty much the same in this patient number 7. He has HbS, one of the alleles. Has converted. One of the beta chains is HbS, and the other beta chain on the second chromosome is HbC. And yeah. Awesome, this is pretty much the same thing. So a normal patient would have mostly hemoglobin A, a little bit of hemoglobin A2. If you had sickle cell trait, you would have half A, half S. If you had the disease, most of it would be S, but you might have some like F, some A2. Just as a compensatory mechanism, your body's making more delta chains, more gamma chains, but the majority of it should be S. Sickle and C is what we looked at earlier, how most of your hemoglobin is C and S. C trait is A and C. Most of it is A and C. Thalassemia major is where most of it is actually F. Remember how we talked about the compensatory increase, overproduction? That's pretty much it. And then thalassemia minor, most of it is A2 and A. You have A as well, but for major there was no A. You don't have anything that's normal for major. And then we have sickle thalassemia. Okay, so moving on to the interpretation of hemoglobin electrophoresis. This is one of the most important parts of the entire lecture. This is normal HPLC findings is where you're gonna have hemoglobin A is going to be around 97 to 98%. Hemoglobin F should be less than 1, and hemoglobin A2, 3.2. We talked about this earlier in the lecture, but the cutoff limit for hemoglobin A2 is 3.5. It should be less than 3.5. Now, a 20-year-old male comes to us with hepatosplenomegaly and fatigue. So when they talk about fatigue in the question, it most likely means anemia, okay? It's pointing towards anemia. When they talk about hepatosplenomegaly, both of them together, you can sort of consider it to be like something that's wrong with the blood, or some like extramedullary hematopoiesis, something, right? Because they're both involved. Your mind can sort of go in that direction. Next, we look at the CBCs. 8, which is very, very low. The normal levels for a female is 12 to 14. And the normal levels for a male adult is 14 to 16. So obviously, 8 is around half of what it's supposed to be. So yeah, the patient does have anemia, and fatigue relates with anemia. The platelet levels are normal, but the WBCs are kind of elevated. Okay, describe the findings of the peripheral blood smear. Now, this is a picture from earlier. We know what this is. But once again, we're seeing target cells. We're seeing nucleated red blood cells. We're seeing Howell-Jolly bodies. We're seeing these teardrop cells. Just like fragmented cells. You can see like this weird thing right here. You have poikilocytosis and isocytosis. And so, yeah, you're not required to diagnose the patient from the peripheral blood smear. You're only required to describe the findings. So that's cool. Interpret the findings of the hemoglobin electrophoresis. Okay, hemoglobin A is 11.7. That is very, very low. Hemoglobin F is 88.3. The majority of the hemoglobin is hemoglobin F. and there is none of hemoglobin A2. Now, we're probably thinking of of thalassemia, right? Beta thalassemia specifically, because hemoglobin F and A are deficient. Hemoglobin A is deficient and hemoglobin F is increased. But how do you differentiate between thalassemia minor and major? Well, it's hemoglobin A2. Hemoglobin A2 should be high in thalassemia minor. But in this case, thalassemia major, usually there is no hemoglobin A2. So our patient has thalassemia major. Interpretation of this hemoglobin electrophoresis. Oh, the answers are written. Oops. So yeah. This is the one that we looked at earlier. Hemoglobin A, 97, F less than 1, A2, 3.2. This is perfect. It's normal. Let's cover it up. Hemoglobin A is 86.7%. Oops. So yeah, the hemoglobin F is 10.6, A2, 2.7, which again, A2 is in the normal range. A is high, but F is higher than it's supposed to be. In this case, the patient is 4 months old, so it's normal. Whenever you see hemoglobin F, you always need to look at the age, because in certain age groups, an elevated hemoglobin F is normal. We have hemoglobin A, 57%. Hemoglobin S is less than 1%. A2 is not measurable, so it's like almost not there at all. And S is 38%. So it's almost like half and half split between A and S. So this has got to be sickle cell trait. On this, you don't have any normal hemoglobin, but the majority of it is hemoglobin S. This has to be sickle cell disease, not the trait. It has to be the disease. Okay, so hemoglobin A is 94.4, which is what's normal. F is less than 1%, and A2 is 5.6%. We know the normal, which is 2 to 3%, so this is more than the normal. And so this would most likely be beta thalassemia trait. Beta thalassemia minor. Remember how we said that A2 is how you differentiate between major and minor? A2 and F. So a low F and a lower F and a higher A2 is indicative of beta thalassemia minor. And if we look here, a higher F, A2 is higher too, but look at how high F is. This is most likely beta thalassemia major. Okay, and this pretty much is the end. This table gives us a very nice summary of how exactly you can interpret hemoglobin electrophoresis. If you were to go through this table a couple times, you would be set for the exam. And yeah, I hope you had a great time in this lecture with me. Once again, if you have any questions, queries, comments, constructive criticism of any kind at all, please feel free to contact me. I've left my cell phone and my email address in the beginning of the PowerPoint. And yeah, I hope you guys have a great rest of your day. And bye-bye.